Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
Hi, everyone, and welcome to the podcast. Today we're discussing light adjustable lens with a group of some of my closest friends, including Sierra, Dr. Sierra Steiner, Dr. Colin Ryburn, and Dr. Lorraine Zimprick. And today, again, we're going to be discussing light adjustable lens. When do we employ it? When do we use it? Where does it work? Where doesn't it? And how do we manage it afterwards? Before we get started, I want a little intro of each of our doctors. Sierra, let's start with you. Where are you from? And also, where's your hometown? Because I feel like that speaks a lot about to why you are the person you are.
Says a lot about a person, doesn't it?
Right.
I'm Sierra Steiner. I am one of the optometrists in Billings, Montana. Previously worked with Dr. Ryburn and have, since the beginning of my time here, worked with our other surgeon, Dr. Swan. I am from Beach, North Dakota, which is a tiny little town on the border of North Dakota and Montana. Population of probably less than 1,000, maybe 900 on a good day.
Love it. Let's go to Lorraine next. Lorraine, tell us about yourself.
Hi, I'm Lorraine Zimprick, and I am an optometrist at our Sioux Falls location, and I work with a surgeon, Dr. Dan Terveen. I did my residency at Vance Thompson Vision as well, and that was 6 years ago, and so been here for that time. And my hometown is actually Hazel, South Dakota, and I have you beat, Sierra. We're a population of 105.
Yes.
Yeah.
That's small. Awesome. Next, Dr. Ryburn, tell us about yourself.
Hey there, Colin Ryburn. I am one of the surgeons that's here in our office in Loveland, Colorado. And as Sierra mentioned, I was previously in our Billings office for a few years before we opened our new Colorado location. I'm originally from West Texas, Lubbock. It's a little bit bigger, small in Texas size, but 250,000, so a little bit bigger than Beach. And yeah, so really excited to be here.
Awesome. Me, I'm Matt Walker, optometrist in Alexandria location with my surgeon, Deb Risfit. I've been here for almost 7 years. I was born in Roswell, New Mexico, but then I moved back up home. And so I grew up in Walcott, North Dakota, town of about 107 people, I think is on the green sign, where I had to go to another town for high school or school. So those long bus rides and, makes you a hardy person, I guess. So today we are discussing light adjustable lens. And kind of an overview to start with. I was going to start of what makes this lens different. The first thing is that there are really no other lenses available in the world that we can put an intraocular lens in and change our mind on the target, to fine tune it down to patients' expectations and make them happy after the fact. I remember my old surgeon would be just digging through numbers and calculations on lens stars and everything of, well, this LASIK and this RK, where do we think, based on all these calculations, it should be, and the stress that goes into that, where that's all kind of gone. It is made of a silicone, but not just the old 1980s and 90s silicone, but a new silicone that has macromers in it that are sensitive to ultraviolet light. And so the magic of it is that this implant is placed in the eye and we have it kind of in the ballpark where it's supposed to be, but we can adjust up to 2 diopters of myopia, hyperopia, and astigmatism in a series of about 3 adjustments. And not only is it awesome for patients, but it also won the Nobel Prize in 2005 for chemistry of this adaptable technology, FDA approved here in 2017, where of course our team was involved in the FDA trials that we're proud to be part of. I think we were all one of the first in the country to utilize the technology, and we love it. So I'm going to pass it off to Sierra to discuss who is the perfect candidate for a light adjustable lens.
I'll talk about my favorite candidates and then you guys can jump in if you like. But I think the sweet spot for this lens is post-refractive patients. So whether they're RK or post-LASIK or post-PRK, um, post-refractive, and then also somewhat picky monovision patients. And the best is a post-refractive monovision patient. As you know, everybody probably knows that's listening to this, the post-refractive patients, and you had mentioned earlier, Matt, are a little bit harder to kind of nail the refractive outcome. And so just having that adjustability on the back end is a really nice way to avoid more surgery.
Love it. We sometimes, instead of talking about ideal candidates, I agree with that. Post LASIK is great, monovision. I wanted to talk about maybe who's not a good candidate. I guess I don't have it in here, but you know, with silicone implants, if there's a risk of a retinal detachment where someone might need silicone oil in the future, we can certainly have a risk of fogging of that silicone lens that can cause trouble. In the label, there's kind of a relative contraindication with herpetic disease, shingles, herpes simplex. Do you guys have any concern about that?
I haven't ran into it, to be honest. I don't know if I would have much of a concern. I think I would be fine pulling the trigger and doing that. Interesting that you just brought up. I'll jump back. We just had a patient who was prior LASIK, and she had just had a retinal detachment a few months back, and they had, since recovered from that, removed the silicone, or silicone was out, but there was still some really small remnants of that silicone oil on the posterior capsule. And so as much as we would have loved to do a LAL in that patient, we opted not to, in the presence of that really small, couple droplets of silicone oil. We didn't want to run the risk of having to do a YAG in the future, and that disrupting that silicone lens. Yeah.
Mark, can definitely fog up, and it almost like it attracts silicone to it, and then it's like cumulative almost, that it can cause that trouble. Since we're on ideal candidates, anybody have experience with LAL plus? Love it, hate it. Where's your fine spot for it?
Yeah, haven't utilized it much yet here, because it came right as I was transitioning from one volume practice to another. So
okay. I use it on a couple patients. I like it more in non-post refractive patients who are dead set on mono. They've done it in contacts or LASIK for 1,000 years. Well, sorry, not LASIK, but contact lenses. They really love monovision, and they're really looking for that big boom near vision, total glasses independency. I would not do it on the dominant eye, but on the non-dominant, where we're already looking for that push, I feel like it gives me a little bit more, or maybe I don't have to push so far for near in order to get as much. But to do it on the dominant eye, I've had colleagues that have done it, and maybe just the distance wasn't good enough. Those are kind of the only ones that I use it on. So next, let's talk about the post-op period with Lorraine. I think you're covering that one. What makes the post-op experience different for both the doctors and the patient?
Yeah, so just like any sort of cataract surgery, we kind of expect that post-op care, the first day to go to their, regular eye doctor, for that 1 week after surgery, be seen at their regular doctor, and 1 month. What is nice to see from, the referring note, the coming back, it is nice to see if they have a refraction, if the referring doctor has done a refraction. I know 1 week might be a little bit too soon, but it is nice to see kind of stability in a refraction. Again, talking about the post-refractive patients, we'll generally start our light treatments about 6 weeks out. Sometimes with those RK patients, we'll push it a little bit further. But once we are healed and 6 weeks out and we have a stable refraction, and the surface of their eye looks good, no dryness, etc., then we start talking about doing these adjustments. And so someone, that wants to do the LAL or light adjustable lens, they also have to be motivated for these post-op visits and these adjustments. So I generally will tell my patients we have up to 3 adjustments, and we always have 2 lock-ins. And so that's an additional 5 visits and kind of a minimum of 3. And sometimes there's another visit if we end up doing a YAG at some point, or we feel that there's some PCO in the way of some of our adjustments, so that's 6 extra visits that the patient could be coming. And I set that expectation right away so that they know this is going to be a lot of involvement on their part. But in the end, this customization of their vision, patients are very happy with it. And in general, it's worth it, but it does take some involvement on their part. The other thing that makes it a little bit different in the post-op period is that they have to wear UV protected sunglasses when they're outside. And so unlike other traditional cataracts, with a standard lens or a trifocal lens, these guys, because that lens is adjustable using UV light, we say anytime you're outside, we want you to wear a pair of UV protected glasses that the company gives us. And we generally will give them a sunglasses pair, a tinted pair and a clear pair, and then also another clear pair with a little add power as well. And so those are kind of the 2 things that come to my mind that are different in the adjustment or in the post-op period. If you guys have anything else to add.
I think you did a good job.
Yep, I think that was great. Again, kind of setting the stage that you're not going to be done in a month. For our patients, post-refractive, we're typically not touching for a couple months on our adjustments, and sometimes even longer. I tend to find I have a low threshold to YAG or to suggest a YAG if things aren't making sense. And I feel like I'm sometimes maybe overly aggressive on tear film, but when I'm not, then it always comes back to bite me. So just because they don't feel dry doesn't mean it's not dry. If their vision fluctuates, or you as an OD listening, you feel like their prescription keeps changing, that is not the implant. That's most likely the ocular surface. One thing that we've done in Alexandria, because patients really, every time we do a light adjustment or we do a YAG, we dilate them. And when they have to drive home afterwards, and especially they're coming from a couple hours away, it can get to be a lot. Sometimes we'll help them out by using a drop like Rezumvi that can reverse the dilation. I mean, it's still 90 minutes until they see effects from it. But if they're a couple hours away, or maybe they had an adjustment in the morning, maybe they could get some of their life back in the afternoon. But yeah, I think the 2 months to me. The other thing too is when we're doing our post-op visits, some of our patients are under the impression initially that, oh, I'm not going to wear glasses after surgery because I chose light adjustable lens. Well, I really try to hammer home like that's not always the case. Even if we're doing monovision, it is not a multifocal lens where there might be a chance you might have to wear a little pair of cheaters, or if we're really pushing that monovision quite a bit, maybe a pair of nighttime driving glasses to help out a lot with that.
Yeah, I do educate my patients a lot actually on, right after surgery, don't worry so much about where your vision is at and what your near vision is like, because the adjustments are what fix the astigmatism, and the adjustments are what really, bring in that near vision. And so don't be, too concerned right away if that distance isn't crystal clear or that near vision isn't sharp. So I actually tell them, don't be surprised if you're grabbing reading vision glasses in that first month. Once we start getting an adjustment or 2 underway, they'll be able to ditch those. It's just right away. I kind of expect that.
That's great. Let's move on to co-management pitfalls. We want to help patients out as much as possible, but also the doctors that are taking care of them, you guys, and we want to help you as much during that process. So then not only does the patient do well, but you as doctors feel, that you're helping and not struggling as much. Dr. Ryburn, curious, any pointers to help us to avoid pitfalls co-management wise?
Yeah, I think there's been a lot of really great advice talking about setting patient expectations. And I think it's also important for us to relay back out with the expectations of what their vision is going to be until we get to that final lock-in. Because with any other lens that we pick, we're pretty close to our final vision within about a week. We tell people a month, but depending on how quickly they heal up. But With that LAL lens, it is going to be about 2 to 3 months before they're going to get to their best vision, just like we've highlighted. And emphasizing with patients that it's a financial investment for sure, but it's also a time investment, but really to customize your vision. We have no other lens where we can customize the vision like we can with LAL. And so I think as long as we're talking about all of that ahead of time and letting the patients know that, usually when they show back up to their offices with their regular docs, they're saying, they told me that the vision wasn't going to be perfect until we start making those adjustments, but people forget. And so just keeping in mind, we're not where we're going to be in the first month after surgery. A couple of other things that we do know as well with that light adjustable lens, the incision size is maybe just a smidge bigger to be able to get that three-piece lens in. That can change the refractive stability a little bit over the first week or two. And it also can leave people feeling like a little bit more, foreign body sensation just from those corneal nerves healing up. So really emphasizing managing the dry eye, lots of artificial tears. We're quick on plugs as well, especially in a lot of these post-refractive patients because they already have some baseline dry eye. Then the cataract surgery makes it more, and then we're putting in a refractive lens where we're trying to get them to their best vision right away. So we really want to make sure the surface is optimized because any disruption from the surface or fluctuating visions delays those adjustments. And to push off an adjustment could mean that they're not getting their final lock-in done until after they come back from vacation. They had this whole schedule planned out and they were really hoping to get it done. And if that's what we have to do because it's best for the patient and their outcome, sometimes we have to do it. But keeping those things in mind, I think, is really helpful. I think other things that, from a co-management side, the conversation from the beginning when we talk to people, I tell people who they've not done monovision, they're worried about, say, like halos from trifocals at night, but are interested in some extended range from light adjustable lens. They're not going to get as much reading vision as someone with a trifocal lens. I tell people not to expect that, to expect that they'll need like a +1 cheater for small stuff up close for reading a book. Um, the other thing is when we talked about like co-management pitfalls, who's not a good candidate? Like who should we not even bring up uh, LAL candidacy? They need to be able to dilate pretty well. An informal cutoff that we have is 7 millimeters of dilation that's recommended by the company. And then people who have asteroid are not a good candidate either because then that can cause issues with that silicone lens as well. So I think those are some of the big ones that I think of when I'm talking with patients and talking with docs in the community and saying, hey, here's who I think would be a good fit for LAL or patients in the office, having them with the right expectations.
Well done. I forgot to mention in my review of ideal candidates, what is everybody's cutoff pupil size for doing a light adjustable lens? On the books at 7. How low have you gone? How low would you never go again? Sierra, can you give me a number?
7.
Okay. Lorraine,
I'm probably at about 6.5.
Colin?
Yeah, 7-ish, there's a little wiggle room. I guess it
Yeah.
depends. The other thing that we do sometimes is I don't routinely put 10% phenol in the clinic, and it gets about an extra half millimeter of dilation. So if they're close enough, and I think they do really well, then I'm not as structured about that.
Yeah. I agree because patients want the vision. We're still going to do light adjustments, and so I think that'll do well. All right. Last part, some pro tips, final pearls with light adjustable lens. If I get one from everybody, what is the best thing that we could do to help our OD community to be the best at light adjustable lens? Sierra, you're the first on the list. I'm going to start with you. Pro tip number 1.
Living in Montana, it has to be treating surface dryness. I mean, the number of patients that come back that complain about their vision and it has nothing to do with the lens or their refraction. It's the tear film and it's always fluctuating vision. I would say that would be the number one thing, just to hit it hard, even if there isn't like physical signs on the cornea, really listen to their symptoms. And if it's fluctuating vision, it's almost always dryness.
Colin?
I think feeling comfortable with new technology. There's always new things that come out. there's a certain amount of comfort in knowing the things that you know, but there's so many new things that we get to see. And especially as a company as on the front end as we are, we're pushing technology and really getting to see the enjoyment of patients. And so if you're a doc who's never seen an LAL patient and you're a bit hesitant, I think just getting excited about seeing that process, it's definitely a process. It's definitely different, but there's some amazing outcomes out there.
Sure. Thank you. Lorraine?
Yeah, and always easy to reach out to one of us, whoever, that you're working with. Easy to reach out and just ask, hey, what am I looking at? What should I watch for? We're always obviously available to help. I would probably say just continuing to relay expectations to the patients. I think we've kind of hit that one hard today, but when they come in for their eval, there's just a lot going on, a lot to go over, a lot of decisions that they have to make. And so any additional help that you can give us to help them is always, helpful.
Amazing. We also have the OD portal on our Vance Thompson Vision website. There's downloadable content, data. I do think the communication is key, where if you don't have a cell phone of a Vance Thompson Vision OD or surgeon, get one, because that's our job. Besides helping patients, we're there to help you, and it's a team effort. And if you don't have a cell phone, get one. We'll post Lorraine's phone number at the end of this, and everybody can just message her, and it'll be great.
Do you mean if you don't have a cell phone or you don't have a cell phone number?
Thank you. Clarification. If you don't have a cell phone number of one of the Vance Thompson Vision docs, do yourself a favor and get one, just because we're approachable. I think we're here to help you and help you with your patient as well. And good question. I hope at this point we all have cellular phones. That's all I have. Thank you for tuning in, and tune in next time for the next amazing podcast.
Thank you.
Bye, guys.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics, where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.